Good afternoon, guys. Can you hear us?
Yep, we can hear you this time loud and clear.
All right. Well, we got a great audience, and we finished the Venus section, so we're excited for this chip shot case that PK told me you guys are going to be doing. Um,
We need to talk to PK
this,
separately.
Michelle, I just want to warn you because I know the details of this case. You have
Okay.
about 80% vascular surgeons in this room, so this is going to be wonderful.
That's why PK left for his talk. All right, please. All right, so we're going to present. Thank you for joining us for the IVUS. Now we're going to talk about utility of IVUS in arterial disease, just to give you an idea of its usage right here, specifically in this case. So again, our team, Dr. Song, Dr. Doshi, we have Jen, we have Mark, and we have the nice AV team. So we're going to directly jump onto the case. Hirsch, if you would like to present.
Sure, we saved the best for last. We're going to talk about the complex CFA IVUS guided intervention. We have a 74-year-old male with lifestyle limiting claudication, right greater than left, with less than one block of activity, Rutherford grade 2, category 4, also with a worsening right toe ulcer, non healing despite conservative therapy. Of note, he has a history of PAD with left toe amputations, insulin dependent diabetes, significant heart failure, and more importantly, recently, about 6 weeks ago, had an NSTEMI which required Impella support left main LAD circ PCI. So he's on aspirin, Brilinta, diabetic medications, and all the GDMT. Next slide, please. So this was his left toe ulcer, or right toe ulcer. Next slide, please. Diagnostic peripheral angiogram. Do you want to go over?
Yeah, so we're just going to quickly show you the chart. I mean, this guy is a vascular path. If you look, we got an ultrasound guided access. But just to give you an idea, you can see the dense calcification on the left CFA, which is our access site. And then you can already start seeing the tram track appearance of the iliacs all the way down from its descending abdominal into the iliacs. Non-occlusive, non-obstructive, but definitely significantly calcified iliacs for sure. Right and left, good patent. But this is, so we had some, we wanted to make sure we can go up and over with that calcification. So we went up and over, stiff angle glide wire, put our 7 French sheet under support. And just to be careful, we had to expedite in 15 minutes. But this is the real money shot. So if you, I'll let it play one more time. I can show you the dry cine, the dry fluoro as well. But this is where all the lesion starts for his right leg. You can see the dense calcification in the CFA extending into essentially the SFA. The profunda is nice and robust. Of course, I'm sure there's, like how we say, whenever there's a bifurcation disease, you cannot say one is normal and one is completely normal and one is abnormal. I'm sure there's some disease extending, but the real problem lies in that CFA extending into the proximal SFA. The rest of the CFA has some disease, moderate calcification, but like you say, it's overall it looks pretty well flow. I mean, not really significant all the way down. And then, of course, below the knee, he does have one vessel runoff. The ATPT are occluded, which reconstitutes distally right there, and coming down all the way to the foot. So the reason, again, like Hirsch talked about, we got the vascular surgeons involved. That's your DP reconstitution right at the ankle. We got the vascular surgeons involved. They wanted the patient to be off antiplatelet, and with a recent non-STEMI left main worsening ulcer, not healing by GDMT and conservative therapy, the plan was to bring him back. He already has a history of left foot amputation, so the idea is try to see if we can prevent this from progressing, where we end up in a worsened situation like amputation, and now we have significant morbidity and mortality associated with that. So for a turn down, so that's where we lie with our lesion. I'll give you a magged up shot just to give you an idea of the extent of the disease, the eccentricity, the involvement, and happy to hear the management strategies. I'm sure we're going to focus on the IVUS part for in this case, but I guess IVUS is an important component in this patient as well. Thoughts? Interesting?
Yeah, I mean,
You want to call PK?
I'm so glad you're doing this case with us. This is fantastic. But I think we have to skip the discussion about should he have had an endo because this was already by a surgical team that said no. And I know we say this callously sometimes, but this is actually a collaborative team where they're actually talking together and actually looking at patients together. So I think we have to agree that we're going to do this from at least an endo approach potentially, but let's talk about what we think about this disease here, Fabrizio, and then also the audience, and how do you want to manage this?
In my opinion, it's very important to see how the profunda looks like because, this changed completely the strategy. if it is also compromised, you can think about a kissing stent maybe, because with such amount of calcium, scaffolding, in my opinion, is the best strategy. Or you can also do from fix only the common femoral
Give me
artery.
a balloon. Yeah.
So I mean, I think that's a really great
For a
point.
balloon.
And the question is, would you put a buddy wire into the profunda so
Coronary
you could
balloon.
also
Yeah.
IVUS the origin and make sure
Yeah.
whatever intervention
Hey,
you did
uh,
build patency?
Yeah.
Actually, it's another stenosis. It's not important.
Can we get an
because you
NC
can
balloon?
the bell stent.
3035,
Sure, but
where's our
it's not the
text?
location.
Give
I
us a
think
4020.
4020
I
NC.
think it's gonna, I think it's gonna depend because we're seeing a single plane image and you see some common femdistal disease, you see some proximal SFA disease. You really can't see the true extent of the osteal disease at the profunda or
Yeah.
what's going on.
I'm going to
there.
give you a more oblique
we
shot,
have to-
try to highlight the
Yeah.
the bifurcation for everybody's comfort. Let me try. We're going to go all the way. I mean, the only thing right to know is this, the IVUS won't even cross the SFA as of now. I mean, I can show you, but here you can see the extent of the disease extending mainly into the CF and the profunda.
Which size IVUS are you using, Michelle?
This is an 018 IVUS. So see
Would you
here.
consider an 014?
Yeah, I mean, that would be my next strategy. Oh, here it jumped. Oh, good. So at least my little bit of pushing and tugging does help. So we're going to start from here, just show you really IVUS, which was what we're trying to focus on
When?
this session. And we're going to start recording the IVUS. So I'm going to pull back. So here you can see the degree of calcification is there, but the lumen is still maintained. So a lot of medial calcification. I'm sure the experts are there. I'll let Dr. Finelli talk about it more and the team right there because those guys are world renowned. So, but as and how I'm coming back.
Ooh.
Yeah, look at the jump and look at my slit.
It's almost like a May Thurner.
And that's my CFA right there. So
Aaron
there's a
got
segment of
excited.
CFA which looks good, and then it has disease again, and then we're under the normal segment, or so-called normal segment. All right, you can stop, Ivis. So if you would like to discuss on what the IVUS really is showing in this case, and especially what would you think based on the IVUS findings is your treatment strategy of treating this lesion? Because I think this is a lot IVUS dependent for sure.
Yeah, can we see where you think where you see the profunda coming in or branching?
Here, let me show you if this.
When's doing it?
Oh, you put the IVUS perspective. Yeah, sure. So when he's going to show you right after the slit, he's going to come back more proximal. And there you're going to you'll see the drop off.
Yeah.
And that's your common femoral just before the profunda takeoff.
So Steve, you're asking about this, and Fabrizio, what do you think seeing now the IVUS in terms of your distal common fem profunda and your SFA at this area? Are you still worried about protecting the profunda in this scenario? Yeah.
Well, the problem is that always I was showing a worst situation if you compare to DSA. But in this
Command
case, I mean, the funda seems that there is some
Hey,
material
command one.
calcification
Photo.
is everywhere.
Can we get the 40
think we-
balloon, please?
More on the superficial femoral artery.
Anybody in the audience want to tell me what's your treatment? How are you going to treat this lesion? Would you do anything to prep it?
Thank you.
Would you just try to get a balloon in there and try to open this up? Or what type of balloon? Shockwave. And you're choosing that because did the IVUS tell you that it was did that kind of help you in that?
I mean,
And what about a scoring balloon? This is a
Chocolate
Phillips.
balloon?
yeah, I was going to ask Dr. Finelli, based on his
Doesn't matter.
classification.
Patients on the
What-
table.
No, but Dr. Finelli, what would you think about getting, based on your classification of having this calcification, the degree, you think scoring balloon is the treatment strategy initially, then shockwave? I mean, I'm sure everybody would agree to the shockwave part of the story, which is what our strategy is. The reason I'm taking a short photo balloon is because my IVUS was stuck. I know my shockwave balloon being so bulky, and in this case, probably if I'm going to go to the vessel size, there's at least 6 or probably even a 7 or shockwave to do in the CFA. I would probably want to be aggressive enough. And for deliverability, I'm trying to see if I can create a little bit of channel with the smaller balloon first, so that way I can deliver my shockwave. Go. Well, what's the size, Van, of the CFA?
9.
No, I agree with you that shockwave could be a good option here. Definitely, you have Or you can do also atherectomy. I mean, in US, atherectomy is, the #1 in the list for all kind of patients, not for Europeans. But
Yeah,
That's
you need
external.
French.
yeah,
Okay.
so you can pick whatever you like, but I think both of them are fine because there is a severe amount of calcium. And what is important also, if you scroll the IVUS images, is also the thickness of calcium, because this is
Correct.
something that sometimes we are not looking, we are just looking on this circumferential distribution, but usually there are a couple of
Got-
points where the amount of calcium is very big. So I think
nice.
this is also a challenge for the IVL,
Yep.
but we can look on the IVUS how big it is.
Yeah, I would say I wouldn't personally go with
Pressure
a
just
high
dropped.
pressure or focal force balloon before IVL. Just
down.
personally, I think
Yeah.
you're trying to
I
get the
agree.
benefit
Up.
of the IVL.
I have a
So to
7
me, you
IVL.
defeat it by being
7
overly
Seven
aggressive
IVL.
just to pre-dilate to get the IVL in there. I don't know if there's no data to that, but I feel like if you're trying to limit the trauma to the vessel, just getting a small regular semi-compliant balloon to get a channel
Yeah.
to then get the IVL is kind of how I approach that. I don't know if that's what you're thinking, Vishal. What
I
do you-
think-
what
I think
balloon are- what type of
exactly.
balloon are you
That's-
using?
That's why I'm just using a 4.0 non-compliant balloon. Idea is, like you said, I mean, the eye was bumped through and went through, but just for the deliverability of the shock wave is what my whole thought process is. But our strategy, I guess my strategy when thinking with my team and when I discussed with PK as well, to try to be as minimalistic at this as possible. I mean, the long-term goal, of course, is to provide complete revascularization. But in this case, because of the signal of disease, even if I can improve the inflow a little bit by just hopefully doing a shock wave and then DCB and trying to get out, would probably still suffice. And then we can come up with an alternative therapy if you have to, or endarterectomy as the final definitive therapy once the surgeons feel they are comfortable doing it. But our
Yeah,
whole
you can
thought
always
process just
temporize this. You can also
correct.
temporize this patient before a future endarterectomy when they're in a maybe in a more clinically stable
Exactly.
scenario if that happens.
Wait, hold on. Just give me one second.
Okay. No,
They'll use it.
that was the thought process. Unless the panel has something else to comment
No,
on.
I think that's exactly what we're talking about in terms of doing what you can in this
Why-
clinical scenario to help them get out of there, kind of in a more stable scenario. Now, question, anybody, we've seen a lot of people use different types of tools here besides IVL. Would anybody consider a rotational or an
Scan?
orbital
It's coming. It's coming.
or
Yeah.
directional in this
There.
scenario? For BZN, yeah.
Nice. Good. Okay.
Nice.
So I think
Give me a small pop.
orbital atherectomy
Can we turn the therapy
Or-
on?
is a good option as well.
In this scenario, would you put a filter, EPD down there?
Generally, I don't put filters, but
Four.
one vessel runoff with a wound, so
Oh, 4.4.
perhaps.
Let's go 2 first.
we can see.
Right, 2.
Done a lot of these in this area. Honestly, I've never been satisfied
Two.
with it.
2.
I don't think I've been satisfied with one time.
Well, is that because you're looking for the luminal gain? Because theoretically, you're supposed to get a compliance increase with both orbital and IVL. I think IVL is safer in that scenario, but is it because of luminal gain you're not happy with, or what is it?
Yeah, I mean,
4.
even
Stay 4.
to make the, even to make the,
Stay 4.
to make the lesion, more dilatable,
Softer.
I'm still not happy with what I get with an orbital.
Okay.
We'll get
Yeah,
it
there is
down a
one
little bit more.
important key point in my opinion, that data support the endovascular therapy for the common femoral artery when we achieve a nice luminal gain after preparation of the vessel, generally more than
Yeah.
30, residual stenosis should be not greater than
Let me go
30%.
down a little bit more.
This
Yeah.
is going
Yep.
to compromise
Well,
Fix my
the
work. I'm
outcome.
gonna go down a little bit more.
Very important
I know.
with
I'm
any
holding
device
that.
we are using to have a nice
Go.
lumen before the
Nice.
final treatment.
Yeah.
I'm going up to 4.
Yeah. Yeah, so I'm just, as you can see right here, I'm just trying to center the most slit open part of it with my IVL to give my emitters the maximum benefit, or the lesion the maximum benefit of the central emitters. So this
Vishal,
is
what
my
size balloon do you have there right now?
7060. If you look at the
And
vessel, it's a
that's to
big size
Is
vessel.
this to pre-dilate or?
This is just a shockwave straight up.
Oh, that's the shot.
Yeah, so
my
4.0
question is,
shockwave.
Why not go with like a 3 mil balloon before the shock wave? No,
I-
before it, so you're not creating, it seemed like that 4 was quite a bit bigger than the lumen. So you're gonna get a dissection started there. Why not go with the smallest thing that'll fit your shockwave balloon
4.
in?
I think.
So I used a
you know,
4.0
the-
balloon to begin with for deliverability, and then I just upsized. I can show you a picture as well, which we took.
Yeah.
Hold on.
I think you could have used maybe if you want a smaller one too, but he used a
Yeah.
4. I think 3, 4, you're splitting hairs, at that point.
We
Yeah,
can use
we
the
didn't flush,
IVUS It's one
Yes,
of the key
yeah.
points of IVUS is to size, the balloon. So we know exactly how big is the vessel, and then we
So-
can pick Scarlet balloon.
Yeah,
the
so we
leader.
can show you, Wen can show you the proximal edge of the vessel is almost like an 8 into going into 9. So this is the slit, and then we come more proximally. That is where our vessel size, if you look at it right there. When can you show? Yeah. So look at it. It's a huge vessel. So that's what the IBUS is showing us. I mean, I know we want to believe this size, then it's a 9095.
Are you saying you don't believe IVUS?
No, I do, but I'm just saying that's what I'm using a 7.0 shockwave, just not trying to be
kidding.
over aggressive and trying to make sure I get good luminal gain. And here you can see it's actually expanding better. Of course, like the whole idea in this case is, like you rightly said, to find the bridge and the gap till the time we have a final definitive therapy like endarterectomy if the patient needs it. We don't want to end up causing more dissection. I mean, here I understand we can use alternative strategies, stenting if possible, but I still want to leave personally some endarterectomy option in this patient. Just let the wound heal, and then we can drop our definitive therapy. That would be the real strategy.
My question is, it was my impression that the severe lesion is in
Walk it
the
out.
SFA, not in the common femoral artery. Am I incorrect?
I think it was in the distal common fem and also
Exactly.
proximal.
Yeah.
Yeah.
It extends from distal common femoral into proximal.
Yeah. I mean, personally, for me, I'm a little nervous in that area, so I'll put a buddy wire, especially if I'm doing IVL. I'll put a buddy wire into the profunda. I was always raised to always respect the P, anything with a P. So
Oh.
I always just as safety, because if something happens,
I agree.
you can quickly, or you can aspirate, something like that. But again, Fabrizio says, never worry about it. I trust him. He's got far more experience with far less tools at hand. So I
So look
trust
at
him.
this. So this is the result after doing all the rounds of my IVL.
Oh.
All right, let's do an IBUS one more time.
So what do you think now, Fabrizio?
It looks nice.
I guess the goal is, if this was mid SFA, you would be unsatisfied completely with
Yep.
this
Correct.
result. And the
Yeah,
question
maybe
is, what do you
it could
do
be-
now?
Could be nice now to see with the IVUS if we
Yes.
see some fracture within
Why?
the plaque, because the goal of the IVL.
Yeah.
Yes, exactly. I'm going
We
to
tend
IBUS
to
right
lose-
now. And then we can come up with a strategy whether anything more aggressive needs to be done, or like you said, probably just do a drug coating on it and then probably call it a day and then bring back the patient later on once the wound healing process starts and then work on it. But can we go live, Ben, please? Perfect. So we're going to start with the live. All right. So I'm going to start distal to proximal. I'm going to pull back. That's the shockwave part which starts, and that's how we do it. It's a little better gain, of course. Like we said, there's a
See the
little bit of
fractures.
dissection right there, but the split was there, which was very narrow, and we still have some luminal gain for sure. And the profunda really doesn't look that much compromised, and that's my CFA. The
So
proximal
Michelle,
mid.
this is just post shockwave without any other post balloon.
Exactly.
correct?
Yeah, exactly. Stop, please. So this is just the shockwave. Yes. Like I said, I just did a photo to deliver my shockwave, but this is purely shockwave. So any thoughts on the next step of how does IVUS help here now? Do we achieve much, not much? Maybe go in, try a higher size IVUS, a bigger size, I mean, or additional therapy, or just we do a DCB and call it a day?
Okay. Would anybody do a high pressure or
mean
another?
IVUS?
maybe less
I mean, give me the
balloon
measurements,
here?
man.
You want to do
Or
Dorado?
DCB. Huh?
Dorado?
I don't want to discuss.
Could be interesting to review the previous IVUS, just to see the fracture of the plaque, because I do not
Definitely.
remember very well.
Yeah. Wen, can you play the first IVUS for Dr. Finelli, please? The first one, yes. So we're going to replay the first IVUS for you right there. Let's start from the beginning, all the way. Yeah, perfect. So that's your first IVUS, Dr. Finelli. This is pre-intervention, pre-shockwave. Even pre-photo balloon, actually.
A 30 cc syringe, please. 30 cc syringe.
8. So we'll do you have an 8 DCB?
No,
Let's
there are several, in my opinion, there are several fracture now after the
Correct.
IVL.
Can you make sure
Exactly.
the
Healing process.
8.0 DCB fits in a 7 French sheath? Okay, good.
Here it got stuck, and that's where it jumped. But you could see that slit, very thin slit, right in the
It's not
SFA.
here, but in the previous area where there was a circumferential distribution, now there are a couple of fractures that I think
Right.
8.030?
more
Hold
options
off
in
on that.
for the therapy.
Would
Okay.
anybody
And when
consider
can you play now the second
stenting in
IVUS
this
post
region?
shockwave?
No, I mean, stent, would anybody consider a plan for a stent in this region? I know, I mean, Ken DeLuce is doing studies on it with
Yeah.
double Bowman NL in this region, specifically.
So just not to interrupt Kumar, that's where I was post shockwave, just to compare. So,
Yeah.
so you're right.
but
There's
you can see some
definitely,
cracks.
yeah. So I think my goal would be
After-
right now, instead of upside. Mhm.
Yes,
Go ahead.
Go ahead.
The SFA after the profunda, I would consider putting a stent in there, because obviously you can't leave it in this condition and expect not to have a problem.
I mean, so if there's a potential for a future ENDARC, would you just try to get
No,
that
yeah.
caliber and leave that osteal SFA lesion?
Can we do an
alone
8
for now
DCB?
without stenting it?
80 what?
What was the 60? Maybe an 80. What's the distal
It's an
SFA
interesting
size?
question.
Distal SFA was at 8,
Yeah,
8,
80.
8 to 9.
80.
Proximal was like 9.
Lesion on his toe,
Yeah.
but he just had a. he
So
just-
so how would you determine that based on just doing the IVL and just, would you do
From
ABIs
452?
afterwards? Right now, how are you going to determine that based on this?
I mean, I guess you could do.
Give me an
APIs,
035
but just-
Trailblazer.
That's not gonna heal that.
035 Trailblazer.
That's-
035
You're just not
Trailblazer.
gonna get enough flow through there to heal that toe. That's not gonna happen.
What are we going to say for BC?
Yeah, I mean, first of all, can we also see the IBUS with the chroma flow?
Sure. You want to do that? We'll do that. Yeah, I need an 035 Trailblazer. Yeah,
Sorry.
when can we start go live on the IVUS this time with chroma flow, please?
So to your
Because
point, I think it also depends.
This is
on-
important for that section, you
Yeah.
know, because give
Yes,
also
I
a
agree.
direction of what to do after, you know, if there is a, because we see some fracture,
chroma
but
flow.
we know, you know,
Thanks, brother.
All right, so this is a chroma flow. I'm gonna start pulling back.
okay.
I'm gonna go now.
It's good.
And that's your regular segment.
Yeah.
You can stop.
So
So what do you think, Dr.
Yeah.
Pinelli?
I have already my strategy in my mind, but I would like to know your strategy.
My goal is to keep life
He wants to know
simple.
what to do. He's at our
No.
beck and call.
No, my goal is to keep everything simple. I mean, I did my shockwave, like you said, you can see the microfractures. The luminal gain might not be as exciting to people because we are used to getting those nice round luminal gain and do all the stuff. But keeping in mind the complexity, maybe the profunda involvement, even the profunda right now doesn't look that compromised, looks good. My goal is, again, for the wound healing purpose. In this case, I would just probably drug coat it with a drug coated balloon and then call it a day. And then once the wound healing happens, maybe decide on the end artery when the left main stenting is more so-called stabilized from a vascular surgery perspective. So that
I guess,
would be
Vishal,
my goal.
The question that we have here that I don't know how exactly we can answer on the table is, how do you know that you've actually significantly improved, other than just getting a visual idea? The cracks and the calcium are better. You're going to potentially, I think you said DCB.
Right.
You might see maybe a luminal gain after that because you are using a different balloon now
Right.
after the IVL. You know, on the table, how are we going to assess that this was actually a significant improvement for the wound healing purposes?
Right. So what
It's a
we
tough
could do, I
one.
mean,
It's a tough
yeah, I mean, yeah, listen, I mean, if now we're talking about real hemodynamics, I mean, the cheap way to do it is, if you really are concerned, we can put a microcatheter down, do a pullback gradient, and say the pullback gradient is not that significant. Technically, hopefully, the perfusion is good enough to supply the vessels downstream. I mean, we can do ABIs post-intervention and all the stuff, but I think that'll be my crude method to probably get a more objective evaluation rather than just doing angiographic assessment and saying everything looks good. I mean, can we do an FFR, all the stuff? Probably not, but that would be my strategy if you really are talking about the dynamics of whether did I really improve the blood flow or just I angiographically made everybody happy, but the long-term benefit did not happen. Unless somebody else has a strategy. What about you, Kumar? What do you do in your practice? Or everybody on the panel?
My approach of this would be like that.
DCB.
I'm assuming that.
Freddie.
Oh,
for
first
this
trailblazer.
ratio,
Okay.
What?
Oh,
the
35
right
trailblazer.
procedure is still a femoral endarterectomy.
Sure.
This is an
I'm
overnight
assuming
035.
that
035.
this is
Yeah. Give it to
either today or, if you want to be very careful, let's say in 3 months. So knowing we saw the lesion on the toe, which is not terrible. So my
Super
main
cool.
purpose with that intervention here is not to transform it into a project that will get a complication like losing the profunda
Supercore.
or embolitis. Because then you do an emergency on somebody who you could
Put the wire
probably
down.
wait 3
Push the wire
the
down.
right operation. The second one is not to make the femoral endarterectomy, which probably will be the right thing to do in 3 months, not to make it tougher. So I would try to keep my purpose for this operation is to reach a lumen that is as close as possible to like the distal SFA or even the popliteal, and not be very ambitious. And when I saw the angiogram, I thought that if I'm treating this patient, I
Give me
would
a
not
CXR.
do anything fancy in the common femoral
Give us a
artery.
O-
I would
Freddie,
the shortest balloon
we need a
expandable
035
stent,
CXI.
proximal SFA, and get you a lumen that's open.
Sorry, what was the last part? You'll use a what?
I would consider for the case like this, without looking even at the IVUS, I would
Walk the
put a
turbos out.
possible balloon mounted stent in that very narrow proximal SFA, get that to a reasonable lumen, not traumatize my common femoral, not risk my profunda, and then wait, and that
Come on,
patient
come
will be
on.
ready for the.
Whatever. Give me
Just
the
to
balloon.
clarify, a balloon expandable
Give me a
stent?
6 balloon.
Yes.
Give us a
Short
6
balloon.
Six balloon.
You're not worried about,
They will have
Short
the
balloon.
right strength that
Open
flag
with-
opened. You cannot put here a 19-old stent. It's not gonna open this. But you can put a 6 millimeter balloon mounted
That's
stent
fine,
that's
that's
short.
fine.
It's not gonna bend. It's not gonna do anything, and you just buy yourself the time
Any
to do
rule
the
for a chocolate
endarterectomy.
balloon?
Doing this is very
Too small.
appropriate if we all agree that this patient is sick enough that you really never want to operate on them.
Yeah.
But I would not go like very fancy when I know he needs an operation soon. Thank you.
This is just a PTA balloon, right?
Is pretty sick.
Look for a CXR.
It's not a
Or
good
NABI
candidate
course.
for surgery, that's for sure. And
Yeah, yeah,
Because I
so-
think the reason why they decided not to do a surgical operation.
Yeah, recent PCI, DAPT, EF
but maybe you heal the
15%.
wound, he
So
starts
I think-
walking and his heart pumps better.
Exactly.
Michelle, was there a pre-procedural duplex showing you, that area?
035 Navi
Yes.
Cross, yes.
So there's definitely, we had the narrowing of that area, like pre-procedural workup was done. I mean, this was, again, like a referred to us, and then we really wanted to make sure we personally talked to the vascular surgeons, and they're like, no, we're not going to touch the patient at all. But with his worsening symptoms, especially his Alzheimer's, doesn't look that bad. But his left toe amputation started the exact same way. So the patient was really concerned that he's going to lose his right foot, the toe as well. So that's the reason we tried to so-called bridge the gap or buy the time, whatever you want to put it as, to make sure at least the ulcer part is taken care of, because he was very concerned, like he lost his left foot, toe last time. He doesn't want to do the right one. So that was our whole consideration, is just to make sure that we do improve his inflow and hoping that we stabilize the wound, the goal, and then probably have a definitive therapy like you talked about, endarterectomy down the lane if need be.
What was your question?
Well, my question is simply, I don't see a lesion, an intervention here that's made enough difference to be hemodynamically significant. And I don't think you're gonna, with just one vessel, perineal runoff, filling the
No.
foot through collaterals. This lesion's gotta look better, or you haven't made any difference. You could compare pre-op duplex to a post-op duplex to demonstrate a hemodynamic improvement.
Right.
But they're still coming back to make that hemodynamic improvement, because I've seen enough of these over the years that we haven't gotten there yet.
Go.
Out.
Yeah, I think, go ahead.
You want me to walk
I
in?
mean, this,
Let it come down.
yeah.
DCB, I haven't seen the picture. I've seen the initial
Go.
treatment, and now the DCB, hopefully we'll see, I think it'll look better, the osteal
Let
process.
them know this isn't DCB.
Over time.
Yeah, I
Give me
think,
the
you know,
DCB. You have a
definitely
7-0?
this is one of the
mean,
Yeah, we
main
have 7.0
drawbacks of
DCB.
IVUS, that we cannot measure the flow velocity, because this could be very
Give me the
useful to
035
see,
trailblazer.
because
035
I have a
Navi
these
Navi
Cross.
patients,
cross.
Did you flush
if
it?
we increase a little bit the inflow, maybe we can produce a little bit better flow in the foot. Obviously, we are far away from the lesion level. That could be an option, because definitely this is a pretty challenging patient with several comorbidities and so on. So I think also it's not that someone that is would like to walk for a couple of miles. So
Yeah, I think
All right, give me
personally, I'll
another
go
3.5.
with a little different balloon first after
Super
that.
cool.
I'll be able to see how it responds before I decide if I'm definitive with the DCB or if I need something else. But then you might run the risk, obviously, of another issue, but hopefully you softened up the calcium enough to get a little bit better
Push the wire.
expansion.
Push
Then
the
see
wire.
with IVUS if your caliber is truly better. But yeah. so-
I think this is one of those cases where a pre-pressure gradient would have been helpful because when you look at the intravascular ultrasound images, there's an incredible amount of acoustic shadowing from the high degree of calcification in the wall of the
Balloon.
artery.
Mhm.
And
DCB,
the
right?
angiogram shows that the lesion was irregular, exophytic in kind of its appearance. So I would imagine that even a transcutaneous duplex would have shown that type of signal dropout, and a velocity assessment would have been challenging. So I think, sometimes when I look at these lesions, if you're, again, trying
What
to
is
figure out what
780?
your technical endpoint
Yeah.
would be.
Give me the
right, your
preps
secret
wrench. Give me the
using is
preps wrench.
temporizing or temporary solution for symptomatic result. It's something where I'd say, do the pre-pressure, because then at least you have some data beforehand for an endpoint.
Give us another 30 cc syringe. 30
So
cc
now,
syringe.
what size, well, you have a DCB in now?
Yeah, I have a DCB in there. I have a 8.0 DCB right in there.
There is another point of discussion because according to some orders, after IVL, pre-dilatation is not necessary.
I know.
So in this case, you did a pre-deal before. How many of you are in favor of a pre-dilatation in this case before DCB?
Pre-DCB, you mean, post IVL, pre-DCB?
Yes.
Go on.
Based on that
What's
initial
nominal?
result, post IVL, I didn't see much change other
Nominal
than cracks.
is 6.
No, I'm agree with
So
them.
I think I would
for
go
me,
with
it's
the balloon.
IVL, DCB, that's it, easy, make not a big sense to use another balloon, just to enlarge, but
8 is
there
nominal.
are some other
Eight's
people that
nominal.
believe that it's much better.
That's why they went back into the balloon.
Yeah, exactly. I think we had issues, and especially with the 7.0, I mean, the 8.0 DCB comes on an 035 wire. So I knew I'm going to have trouble going down with an 8.0. So, and I had an Owen 4 system because of the wire. So that's why I just wanted to switch my wire to a little bit more like an 035 wire so I can deliver my DCB. And that's the reason I had to pre-dill and take my catheter down. But I think,
Yeah, were you saying that you would not pre-dilate if you're gonna go DCB this lesion? Is that what you?
You are going here.
So,
Depends.
yeah,
I mean, the other option for me, if not a DCB, was a stent. And definitely
Sure.
it's not IVL stent post-deal maybe. And there is something interesting here. If you have seen the pre-dilatation, the shape of the balloon
Give me a
was
Spartaco again.
completely dilated. And now there is still the dark bone. So this
Yep.
means
Right.
that this lesion will not react very well to dilatation.
is that
So
the
yeah, something
osteal
that we have
SFA
to
lesion now?
keep in mind now.
That's the osteal SFA area now, right?
yeah. Yeah, that's what the area is. The slit ridge is more the osteal SFA put on the IVUS.
Freddie, give us a new Spartacore.
Why not?
Can you tell him
Why,
to?
why,
He's not paying attention.
I mean, personally, I would want that to open up a little bit more because that stent's gonna permanently have a dog bone. You're gonna have that personally. I mean, I have some friends who are, who believe in this scenario, they'd shock Hawk and DCB or stent. And I know it's crazy, but in the SFA or at the origin, when you have this eccentric stuff, you've already softened it, then they'll direct the directional right at it, because otherwise you're gonna have potentially a permanent indentation there that's not gonna go away, and that's gonna be potentially half that vessel. Yeah,
that's-
but
that's-
you see
that's
how
another
it
good
doesn't
point.
improve there all the way? Yeah.
Is there pre-dilating with a cheaper plain balloon is going to give you an idea? If you still see this on your pre-dial, would you still go ahead with a drug-coated balloon, or would you say, no, now I'm going to do my stent to keep that open and I've saved the whole drug-coated cost?
But on the previous balloon, there was not a dog bone shape. Was a regular shape of the balloon. Yeah. No, post IVL,
Spartaco
post
through this,
IVL. Or
Do you want
DCB.
to or do you want to
An
exchange?
inflated balloon, it was a regular
exchange
shape.
it.
So this,
I don't
I'd
think,
say probably be saved.
Vishal, did you do a
Yeah.
balloon after the IVL before the DCB, or you went straight DCB, right?
No, I just did a 6 or short balloon because of the eccentricity of the calcium. My 035 catheter would not go down. But that was just that
You
one
did a
spot
6.0
where,
in a 9.0 vessel.
yeah, I mean, I just wanted to get that 035 down. And then that's it. Like they talked about, just do a shockwave, do a DCB and see the gain. I mean, the issue is, let's say if you have still dog bone right there, would anybody do a stiffer balloon, let's say like Dorado or something to get luminal gain, or how would you approach that just in case? I'm sure we're not going to get like a perfect ideal result like we talked about, but at the same time.
I would go back to the fact that this was, again, a very irregular, highly calcified lesion in a patient with a low ejection fraction who cannot have open surgery. So if you were to perforate and have extravasation, I mean, going
looks
for
much better.
perfect is
Yeah.
is going to be the biggest fallacy here.
That
I
looks, I mean,
agree.
to me, it looks gravid ibis, kind of just
Yes.
to help us see what you're seeing.
Yeah, I'm going to just
So that's a
quickly
very-
exchange my wire. We go to Iversit, but I think you can see the shelf of calcium right at
Wire.
the proximal or the ostium of the SFA. That's the biggest limiting factor. But again, if you start going more aggressive, then we start going in a deeper hole. So, like I said, I want my surgeon friends to be the ultimate definitive therapy once this is taken care of. But at this time, I mean, this probably would, I don't know, should hopefully buy him some more time. Again, we can debate about it, which I totally agree, because there are so many parameters which need to be looked at, especially the
Final
hemodynamics.
Surgical treatment.
But
I mean,
yeah.
if we get a reason, that's what seems to be the thinking
mean-
there, that whatever we're doing it to get it ready for a surgeon to do it. I think in this one, if you get reasonable results and the patient's or other medical comorbid conditions are still going to be there,
Yeah.
I would just, we can get it
We'll
done
leave it,
without
yeah.
surgery.
So we usually
I
follow
think
them with
Emerald's
routine
goal is to
ultrasounds, which
get
I think is
some
very
treatment to get them
important.
out of this current scenario, and if that is enough, then you're done anyway.
Yeah,
But the patient
exactly.
also had rest pain.
Yeah, so we follow routine
Good to see. That's
ultrasound
not
on
the
these
biggest problem with
patients.
this patient right now. It's the heart, it's
All right,
everything
we go with
else, right?
Ibis.
So it's not like you definitely have to do a surgery. It's just that you
Yeah.
do enough to not cause an immediate surgery
Correct,
on the table
correct.
potentially is probably what the goal
But
is here.
yeah, and I think it was rightly pointed up in the conversation how to do a post-intervention
want-
arterial duplex, which is a great marker indicator of seeing how well the patient responded. Even though, of course, we will follow them clinically, but that would also give us a very good idea of how the whole disease progression or the treatment has happened. All right, so I'm going to take the IVUS down all the way. Perfect. Let's start, please.
Yeah.
So it looks better for sure. I mean, there, like I said, there is some dissection right there. There is flow, but there is definite
Yeah.
luminal gain for there, not
You wanna tell
anything
us what you're
flow
seeing here,
limiting.
Vishal?
Yeah, so if you really look down, I'm going to play it one more time for you. Can we play it when? Stop. So when you start distally, it looks, you still see the calcification, but we obviously, like Dr. Vanelli said, compare the luminal gain, which we see it. The slit is actually more open, not optimal. You do see those cracks right there when you saw, and that's your dissection right there into the CFA, which was there. It's more of a calcification. But essentially nothing like an open flap, which you could visualize. Sometimes it's harder to see it. Sometimes they'll say, how can you visualize? But sometimes you could visualize a flap, which would suggest that there is something really dissected, which needs to be taken care of. In this case, as of now, it doesn't look that way. So I think we can take another picture, but keeping in mind the IVUS and everything, I think I'm happy with stopping right here and then follow the patient. And I guess we take him both
The
clinically
audience,
and
so
by
Vishal said
ultrasound.
he'll do whatever you say.
Yeah.
So
Is my wife there in the audience?
would try something adjunctive here?
Live to fight another day.
So the enemy of
That's
good in
amazing.
this scenario.
Yes. That's what it is. The enemy of good is. I think the profunda flow is good. I don't see any branches or margins compromised. So that is, I think, very important. Like Dr. Finelli talked about, the issue is not to end up in more trouble than we started, especially the profunda being the lifeline off the leg, because that's what's giving most collaterals all the way down. So I'm going to quickly take a picture below the knee as well. Give me 1 second.
Yeah, like Srini said, it's gonna be really interesting when we see the actual data. It's gonna take years, obviously, for common femoral stenting and all that, which is being done in Europe. At least, I
less
mean, I'm sure for
angulation.
Asia,
Yeah.
better, but we'll see. Don't know.
What I think about too is like if you read some of
Yep.
if you read some of the wound care literature, they talk about some of these wounds still healing and failed below the knee intervention.
Yeah.
So you got to think about that too. And
Wow, look at
I
it.
guess
Much.
the biggest thing when you just don't want to end up in the operating room unplanned or in an emergency situation with this gentleman being so
What do you
sick
do?
and having anticoagulants on board. So
I'll say I agree with you on that. I mean, I do doing primarily wound care clinic and taking care of patients. A lot of them just don't have good wound care, and that's kind of one of the first tenets. So there's a lot of that you have to kind of assess before going a little more into this kind of a scenario. Is have they truly been optimized on wound care?
But I think look at here, if you look at naturally, the flow is much faster, is much better, more collaterals, of course. We still have to get a
Yeah.
straight inline flow intra-pop, but he's just moving. But
It
I think,
looks significantly better.
yeah,
Yeah.
so I think that should for now suffice.
You can
Seven
breathe
and a
now,
half French
Michelle.
short.
I know. Oof.
7.5 French
Thank you,
short.
Kumar. You're always there. I know. That's why I love you, my friend. But
Thank
yes.
you.
7.5.
But I
Yeah.
think the IVUS did give us a very good perception, like Dr. Finelli talked about the cracks in the calcium, if there's any dissection, how about residual stenosis, and the treatment modality, whether DCB or something else could be a lot driven by what we find in the IVUS, especially in very calcified lesions, which could be the biggest problem from an endovascular perspective. But I'll let the panel talk more about it.
Yeah, looks like we have a couple of questions still here for you, Michelle.
But I mean, if we could find a good solution to it, that would be good, because I do stuff in New Orleans, but I also do a lot of stuff in very rural Mississippi, where those patients don't want to come to New Orleans, and they don't want to come to a place where they can get an endarterectomy. So if there was a way we could find an answer to that, but right now,
Not there yet, yeah.
Yep. Awesome.
Comparing the minimum cross-section of your first IVUS before the dilation and our end result, just to see what the cross-sectional area looks like.
Did you hear that, Michelle?
Yeah, let me go see
question.
What's the pre-cross-sectional area when we started, and then post all
Final.
therapy cross-sectional area in that tightest spot? Yep, so that's 5.
Yeah, that
What's
was
gonna be your threshold
5.6.
to say it's, you know?
And the last, yeah, higher up. When, yeah. Perfect, yeah. Right there. Yeah, I went from 5.6 to 16. I went almost like 3 times. So I think
Great.
that should.
So Michelle, the question was, did you use all the pulses on that IVL, and did you try to focus kind of the
Yes.
center of the balloon at that
Yeah,
area?
so if you see my first IVL was a little bit off-centered, so I actually pushed the IVL down so that my central emitters would come in, and I use all the pulses. That in these cases, we use all the pulses. I try to use in almost all cases all the pulses, unless it's a very focal stuff. But in this case, we use all the pulses of the IVL. Definitely.
Yeah,
I mean,
a
that's
great
always
question.
been a
I mean,
strategy.
there's several different types of IVL coming out in procedures and trials right now that have different technologies. So we'll see if that helps maybe address some of those limitations here.
Yep. Awesome. All right, but I think
Michelle, one more question,
Sure.
Michelle. What pressure did you go to on the IVL?
so we went 4, and then we go up to 6. So we go 4, fire it, then go up to 6. Yeah, exactly, and come up. I mean, we don't want to use shock wave really as a post-still. We want to make sure it's done by what it is, and then there's just ideas to just size it so that way we have the maximal effect on the ideal pressure they recommended. So yes.
Any other questions from the audience or faculty? Rizio? Well, great. Thanks so much, guys.
Thank you so
Thank
much.
you for being brave enough to take that on. Yeah.
All right. Thank you so much, guys. Thank you, everyone, for joining. Thank you.
Great job by your team. Yeah. And yourself.